Let's start at the top. There's SLAPs. There's 10 types of SLAPs. If you didn't know that, they're 1 through 10. Hopefully you know them, the classification system. But what are the causes of poor outcomes after SLAP repair? Well, first of all, it's poor patient selection and misdiagnosis, which is a lot. Failure to treat the coexisting pathology, or failure to correct the predisposing mechanics or the pathoanatomy. And then there's the technical pearls. So remember that the SLAP actually inserts on the side of the labrum. It doesn't insert on the top. That's the bottom of the labrum, just mechanics, or just pathomechanics. Technical pitfalls, there's improper anchor placement. There's suboptimal absorption characteristics of the anchor that you choose. There's an overconstraint of the biceps tendon. There's failure to provide favorable biologic healing. And then there's the persistent prominent malpositioned suture knots, as you see in this picture. So John Conway and I talk about this good SLAP, bad SLAP. It's kind of a joke between us, but the SLAP, there are actually good SLAPs. It's an adaptive process for overhead athletes and swimmers and tennis players. So a good SLAP is something that is purposeful. It's a beneficial adaptation allowing greater labral mobility, humeral elevation, external rotation, velocity, and performance. So a pitcher has an adaptive SLAP lesions, most of the good ones. The problem is you can get a pathologic process or a bad SLAP causing translational and rotational instability and micromotion at the extremes of motion of these athletes, and then you get a decreased performance, and then you got a problem. So a good SLAP looks like this. They get pain relief when you inject them subacromially. It's a type 1 or a type 2 SLAP that's chronic. It has good tissue, and the SLAP kind of rolls back. It doesn't peel off. It just kind of rolls back. Your biceps is stable. It doesn't invaginate. When you take the arm out and you move the arm around, it doesn't invaginate, and then there's no rotator cuff tear. However, there's the bad SLAP. Now, the bad SLAP, the pain's not relieved with a subacromial injection, so there's not secondary subacromial impingement. It's an anterior lesion, or it's a type 3 or 4 lesion. It's an acute event. There's a SLAP event where the patient throws, and all of a sudden his arm just kind of falls to his side. That's called a SLAP event. The tissue is bad. It's unstable with Aber, so now it peels off. So when you take the arm out, you always got to take the arm out of your device and move it. As you move it in external rotation, it'll now just peel off instead of just roll back. And there's usually associated with a rotator cuff tear like you see on the bottom. What about a segment, a superior segment? So there's a mobile superior segment. Is that a bad thing? Well, I would tell you yes. I would say that would preserving that make a difference? And the answer to me is no, because it's called edge loading. So if you know anything about neuroanatomy, you know there's free nerve endings in the labrum. And so what happens, it edge loads the labrum, and now you get pain. So what my suggestion to you is for that is you remove it, like I show here in the slide, and then what you do is you use a knotless repair up top. And I'm going to tell you why, because this is when I first saw this picture. Neil Elitrage sent this to me, and we all have it. We stole it from him. And this is a high-level volleyball player, and you can see that that knot is going right and causing that rotator cuff tear. And that's when he said to me, I'm worried about these knots. And I said, well, after seeing this video, I surely am too. And that was about 5 years ago. So, so does rotator cuff cause humeral head abrasion? So do superior and posterior suture knots cause rotator cuff injury following SLAP repair? And should we still be tying knots above the equator? Not as important below the equator, but definitely above the equator. Should we be tying knots? So here's a study. It was done in JSES, and there's the pre-op. Now look at the post-op. That's the rotator cuff, right? And look at the rotator cuff tear, and look at the knots. See the knot stacks? They're not even covered, and now we have a rotator cuff tear. So I would say to you, I'm going to propose to you that knotless labral repair with push locks, it eliminates suture abrasion on the chondral surfaces and synovium and the rotator cuff. It restores the anatomic position of the labrum on the glenoid, and the cannulated anchor now provides you an extra channel for marrow like we've seen before. So I'd prefer to do one of the two constructs to the right rather than the one on the left, which I think you're going to get into trouble with. Okay, so you think we're good, right? We're pretty good, right? Well, knot strength varies widely among surgeons, and the study was actually done here. This study was done here, and we had all these guys in here, and everybody tied knots. So there's considerable variations in knot strength exist between arthroscopic knots tied by surgeons. So literally none of us can tie 5 consecutive knots of any type with any kind of consistency. Whether you think you can or not, you can't. If you have 10 years or less in practice, you are actually a better knot tyer than if you have 10 years or more in practice. And if you have greater than 200 arthroscopic surgery cases annually, you failed to tie knots any better than the guy that had 100 or 50. So we think we're good knot tiers, but none of us really are. So the other problem is the knots move. So you tie them on the labral side, on the one farthest away from the glenoid, but guess what? The knots move. So movement-induced knot migration was fairly prominent if you looked at this study in arthroscopy. So even though we think we're there, we're really not there. And then the question is, well, if you do a suture versus a knot, so you say knotless versus knotted, are we any better? Well, the papers that are coming out says we are definitely the same, if not better. So you're not losing anything if you compare one to the other. And so why did I change? So I changed, believe me, Bill Benovitz harped on me for like 3 years about going, you gotta go knotless, you gotta go knotless. I don't wanna go knotless, I can tie knots well. Finally, when I went knotless, I kind of never went back. And these are the reasons why I kind of changed to Labral Tape. I can use short 2/9 push locks, which aren't as long. He mentioned the shorter drill. What you don't know is labrums or glenoids are different. So if you're off a tiny bit, you can go right out the back of the labrum, or right out the back of the glenoid. So short drills in small holes is a much better way to go. The Labral Tape versus fiber wire is 39% stronger. It has a 37% more pull-out strength, and that's the failure mode. The failure mode isn't the anchor coming out of the bone. The failure mode is the giggly saw of the suture going through the labrum. So that's a 39% better. So beware of small glenoids. So my problem for these guys, I said, look, some of these small gymnasts have very small glenoids. And you say, well, you got to know what a normal glenoid is, right? Do you know what a normal glenoid is? Well, it should be 39 millimeters top to bottom in an average. It's 29 across the bottom, and it's 23 across. And that's Joe Iannotti's study of 140 different glenoids. So that's normal. But look at the range. It went from 30, 18, and 21. So it was 30, 18, 21. Those are much smaller. So smaller glenoids, beware of those. Because this is what happens. You get a smaller glenoid, your anchors are too big, you have too many anchors, and you get these things called postage stamp fractures, which are really hard to deal with afterwards. So if you don't put big anchors in to begin with, now you don't have as much of a problem. So then the solution was obviously go to smaller anchors with Labral tape or some kind of sail tape. So why do I use now 2.4 millimeter short push locks and 1.3 millimeter suture tape for small glenoids? So I've gone to that. So in the bigger ones, I'll use 2/9s with Labral tape, and in the smaller ones, I've moved to 2.4 millimeter push locks and suture tape. Why do I do that? Because number one, they're a poly blend. They've got some polyester in them, so the cells like them. There's no knots. Their pull-out strengths are almost equal in the recent study to the 2/9. So I've got a 2.4 with less suture, smaller hole, smaller drill, and now they're almost equal pull-out. And if you compare suture tape, that's a single strand of tape, not a cinch stitch, a single strand. They're equal strength to a number 2 fiber wire, but overall they have a 10-pound greater labral pull-through strength than the fiber wire because of their construct. They kind of look like this. This is what I'm going to. This I think is going to be the one of the future for me, is a short 2/9 push lock with suture tape in a cinch stitch fashion. So this will be my construct. The cells like it because it's a poly blend, so the cells like to cover that up. So the knotless advantages I'm going to try to give you is it saves time, eliminates steps. There's no possibility of knot impingement. You have pound in screw, and you have also other options of screw-in options. So if you don't like that, you can use a screw-in option. It's bone preserving. It's in the anchor design. It's very versatile. You can use a suture first technique, or you can use the knotless suture tack, where it's an anchor first technique. You have multiple suture options. So if you don't like the one that I think would be good, you have all these suture options. You got fiber wire, fiber stick, fiber link. You have Labral tape, you have suture tape, and then sail tape. So operatively, you got to know your portals, okay? This is how you get around. So you got to know these portals. If you don't know how to do these portals, the 5 o'clock, 7 o'clock portal, you got to learn. Percutaneously, you can do them, but that's how you get the whole way around the labrum. So please, if you don't know that, ask the technical consultants in there. They will show you how to do that. Just a quick little case. I don't want to go over, but I want to show this. So here's a picture, and they get these type 2B slap tears. The torpedo is a wonderful little instrument because it can get under the labrum quite nicely. You want to elevate, and you want to prepare that rim. The mistake people make is they spend too much. Oh, there's the lesion. Let's fix it. No. You got to prepare the rim to accept the sutures, and so you don't just spot weld it, you heal the whole thing down. It's really important. And I harp on it with my fellows all the time. I say, you got to take, I'm not a very patient person, but now I'm patient for this. You got to be patient for certain parts, but this I'm patient with. Anyway, and I use this little meniscal rasp, which works very well also. There's tissue resecting burrs that you can put in there and push it off, or tracting burrs, you can push it off. So after this, then what you want to do is, I typically will use a reel pass because of the angle, and it's a very small aperture. So I put my spinal needle in, and I typically use this low profile cannula. I don't like the metal one as much, that's just my preference. But Arthromex makes this clear 5mm low profile cannula that I can see through. And this is the reel pass. The curvature is really good, the aperture is really small, and it's really easy to work. I work all lateral decubitus, a lot of guys like beach chair, but it works for anything. It's got 10 yards of suture in it. So you can use it for the whole case. And I simply shuttle through labral tape. I'm not a big fan of grabbing a lot of the gutter tissue. I think you're just asking for trouble and decreased range of motion, especially in throwers, so I stay away from that. So I'll pass these two initially. Stay out of the gutter, unless it's an offensive lineman, then I grab as much as I can. Because those guys, you know, they like to hold, so if you limit their external rotation a little bit, they really like it because they don't get called for holding. Because their arm's stuck like this. Oh, this is great, Doc, this is great, I can. That's how they call them, by the way. They get outside the plane. Once they get outside the plane, that's a hold. This is not a hold. You can grab as much as you want here, but once you get out the plane, you're done. Anyway, I drill it, and then you got to leave a little room for the labrum. So this is a short 2/9 push lock. So you got to leave a little bit of room on it. Don't strangulate the thing for the labrum, all right? That's one of the keys. So you kind of say, well, how big's my labrum? And then you'll make sure it's, you know, and that the cutter that he talked about, you want to spin the cutter. See, I spin the cutter and I shove it in the hole. That way, none of the suture's above it. So we're going to move on here for time's sake. So the next thing is, if you want to go low, like a type 8 slap or posterior, you can use this same system, this percutaneous system. They have the percutaneous system, and use the same anchor. So it's a two cannula technique. That cannula down there is safe. I didn't believe it. I didn't believe the Curlin Job study, so I came to the lab and I dissected, and it's about 3 centimeters away from the axillary nerve in that position. I didn't believe that, but believe me, that angle in the top left, that 35 degree, that's where you want to be, and that's kind of how you get to the low parts. I want to say one thing about slap extensions. I want you to know about this. In baseball players, there's a slap extension. It's called a type 8 slap, and they'll split not only at the labral junction, but they split right through the labrum, and this is what I'm showing you. That's the split. If you don't fix both of those, you're not going to help them. So this is a third group Ben Kibler and I talked about in our instructional courses. So you initially get a 2B slap on the top, and then it splits the labrum. Well, why does it split the labrum? Is because there's a natural, those are the two areas, there's a natural cleavage plane right there. This cleavage plane, it'll split here, and it'll split there. If you don't fix them both together, that picture's not going to, that thrower's not going to get better, and you can do it easily with this labral tape. So let's talk about outcomes with this strategy that I'm giving you for anterior, posterior, superior. You should expect about 80% return to the same level after a slap without a rotator cuff repair. Rotator cuff repairs are a total different thing that you can talk about together, but if you're going to do something that's traumatic, it's 90%. So if you have a traumatic anterior instability, posterior instability, it's about 90% return. If you look at the SOS system, which we do, the SOS, if you look at VAS, SANE, ASES, and simple shoulder tests, they're all somewhat better than the older techniques. So my suggestion to you is do no harm, and you want to think about going knotless. It's much more efficient, it's faster. You can do it for superior, anterior, posterior, and really around the world.